Hello and welcome to this Prader-Willi syndrome training video on behavioural and mental health issues in Prader-Willi syndrome. My name is Don and I am father to a son, Richard, who has Prader-Willi syndrome. Shortly after Richard was born, I, along with others, established the Prader-Willi Syndrome Association Ireland. I have since also become involved in the International Prader-Willi Syndrome Organisation. In 2014, both organisations cooperated to produce a series of training videos. This one on behavioural and mental health issues in Prader-Willi syndrome contains perspective from families as well as an overview of issues by Professor Tony Holland. The production of this video has been funded by Maynooth Students for Charity Galway Cycle 2014. We hope you find it useful.
Oisín does have a high interest in food. He doesn't search for food and he doesn't take food, but he would have a high interest in food. If we were going somewhere new, he would want to be assured that lunch will still happen, his evening meal will still happen, his snack time will still happen. If there's anything out of the ordinary, you have to reassure Oisín. You know, you have to plan, he has to be forewarned and all these things. For our family, there is a lot more planning. You can't be spontaneous as around parties or around food or around outings, because Oisín needs to know and he needs to be pre-prepared. He needs to have a plan in place for every day, really.
I suppose Aoife shows the liking for food.
Yeah, she likes her food.
But we have it controlled, I suppose, as much as we can.
Once she's involved in it, she's quite happy to even put off having it, you know, once she knows it's going to be there. And I find she can be a little, she can obsess a little bit about things, and it can be very hard to distract her from it sometimes. And she can get a little anxious at times. If you can catch it before it escalates, distraction usually works. And then sometimes I have to take her away somewhere quiet and just chat to her and give her a cuddle and, you know.
That's what I find. I think she's at an age now, she's 4.5.
Yeah.
And if you actually just kneel down and
explain,
talk to her, tell her, like, this is what is happening.
Yeah.
Or if she's a little bit bold, tell her, you know, it's like any other child.
Yeah.
Just, you can't do it. You can't be bold. And
yeah,
it works.
It works.
It
usually,
works.
yeah.
Now maybe it mightn't work
all the time.
You know, but it works most of the time.
She certainly has stubbornness. Okay, she certainly is stubborn. She absolutely hates a change of plan or a change of routine if it's not well managed in advance. So where we would run into difficulties, if we have planned, for example, to go to for a walk at 2 o'clock and something upsets that walk at 2 o'clock, there may be a tantrum or an upset time. While the tantrum will be very, very short, it's very difficult to manage it because you've broken the plan. So what I have found the best strategy to cope with changing routine, and it could be anything, is to actually, if you know it's going to change, to get her ready for the change. So you plan in advance, and she's the happiest girl in the world if she knows what's happening and when it's happening.
My son is 10. I think he exhibits quite a number of the behavioural characteristics typically associated with Prader-Willi syndrome. I understand most of the behaviours that to, I think, other people might seem a little unusual as stemming from anxiety. So in my opinion, that's really where the big problem for my son is. So he engages in a lot of repetitive behaviours. He also asks a lot of questions, repeats the same question or repeats assertions, which I think generally he's doing to gain reassurance that something is going to happen. So I do think he's a very anxious child. I think an awful lot of his time and energy goes into managing this anxiety. As such, I think anxiety causes quite significant problems for him, unfortunately. If he didn't have to spend so much time worrying about things, thinking about things, needing to know what was going to happen, needing to know about everything and everyone, then he would have an awful lot more time to do things that I think might be more fulfilling for him. I think anxiety also probably casts a cloud over a lot of family occasions in our house. I'm thinking of things like holidays, birthday parties, Christmas. It seems to me that I spend, and indeed my husband spends, an awful lot of time preparing for events, trying to preempt what might happen, trying to second guess what other people might do, trying to have plan Bs and plan Cs and plan Ds in place to prevent anxiety and the possibility of meltdowns. It also seems to me we spend an awful lot of time dealing with upsets or meltdowns. And at the end of the day, at the end of many occasions, I conclude that we actually spend very little time just enjoying the event itself. So there's a big build-up in terms of anxiety. Often the event itself goes off reasonably okay, but then there tends to be a hangover period of anxiety and stress being released afterwards. I believe that his anxiety levels are always, I suppose, elevated. So it only takes something quite small for him to go to a place where he actually can't cope anymore. So for example, he might need to go to his room, sit on his couch and cry for 10 minutes. So I have worked a lot with my son, and I think he has a good understanding of the issues regarding anxiety. So we've come up with a keeping my cool plan. So he has a little toolkit of things he can do when he's not feeling calm. Yeah. So unfortunately, when one has lost their cool, it can become quite difficult to actually realise that. So sometimes I think another person needs to step in and say, okay, right now we need to do one of these 5 things. So my son would be given a choice. Do you want to sit on your couch for 5 minutes, or do you want to do this Sudoku? So for him, things which I've heard other people refer to as thought blockers work quite well. So something that engages all of one's attention and distracts them from whatever it is they've been thinking about. So that might be a Sudoku or a word puzzle or something like that. So yes, upsets, it can be shouting, it can be crying, it can be, I suppose, just an inability to do anything, almost as if anything is going to cause a problem, an inability to move from a single spot even.
When it comes to something like food, not only food, but habits or norms or structure to the day, if you change it on a very short notice, then she can actually get very, very annoyed. And when she does get very annoyed, her ability, there's no rationale. There's no way you can actually talk to her or talk through the situation unless you really spend time with her to see what is that switch that's just happened. It might be obvious in some cases it may be not. And without giving in all the time, in some cases there's no other thing for it, but you might actually naturally give in. We all live our lives. We all have, other pressures, time constraints, and this, and you're okay, what am I supposed to do in this situation? It doesn't always revolve around food. It can be a situational thing. As I say, it can be like the supermarket where, she's gone down the aisle and she thinks she needs something, and you say, no, you're not going to get it. And you can walk up and down 3 or 4 aisles and you come back, she'll still be sitting in the same spot on the floor. So one of the strategies is live today. You might win a battle today. It doesn't mean that you'll encounter or the same situation will present itself tomorrow. Do your best. There are situations where you think you're totally in control, and then something comes blindsided and it just catches you. But just think about it. What would you do if without the PWS associated with it? What would you do? And then tomorrow morning or the next day, it's a new day. Everybody wakes up, fine. Things might go right, things might go wrong, but just see it as a new day.
Tantrums. Tantrums is what Mark has started with. Mm-hmm. We don't know, he's 12, going on 13. We don't know whether we're looking at a teenager with tantrums or a Prader-Willi child with tantrums. So we have to get the balance there. He's just banging doors, answering back, but my other 2 sons do that as well. So we have to see, it's starting, I can see it starting, but we have to see, is it Prader-Willi or is it a teenager? But it is, we can see, and how it escalates very quickly.
Somebody once said to me, look, all children have tantrums and behaviour problems to a degree. But in my opinion, there's a difference between normal behaviour problems and tantrums and Prader-Willi behaviour problems and tantrums. So you can see where they're just being a kid, and then you could see other ones where they're not really in control of what's happening, okay? And like emotional outbursts that are, he's carrying on like a 4-year-old where he's 12. Okay, so there's a big difference. Change, can't handle change at all. Okay, we try, when we know change is coming, we try and avert it. And there's times where you literally know, Sunday mornings are dreadful.
Oh, Sunday mornings,
Sunday mornings are dreadful because it's out of the routine. Routine is very important. First 4 days of a holiday.
Anywhere we go is...
You might as well check the return flights early. But then he settles into his routine and it's fine then. but it's hard work. And to be honest, you can see the tantrum coming, and sometimes you just say, oh, come on. And you kind of, okay, bring it on. Let's have this row and let's get it out of the way. Because you know sometimes when it's simmering there in the background, it's maybe going to be 3 hours before it really erupts. And sometimes let's just get it out of the way, get him to his bedroom, let him settle down, and then we can go to shopping centre or whatever it is.
Yes. If he wants a particular mug, if it's in the dishwasher, wash that particular mug and give it to him. And that stops a tantrum. And it does. We have seen, you know, don't just say, well, you have to have this one. Give him what he wants. Not all the time, but it does help. It really does.
Yeah, Mark responds sometimes when you stand up to him, because he'll push the boundaries all the time, okay? And if you give in, you might as well just hand your life over to Prader-Willi syndrome, okay? And you can't do that. You do have to set boundaries. You do have to be firm at times. You do have to have the row. But then there are other times where, yeah, you can give in. It's give and take. You have to know when to stand firm.
It also depends on the humour we're in as well.
Absolutely, yeah. It's not clear cut. It's not black and white.
Yes.
And sometimes you do have to go somewhere. And like it or not, he has to go with you, okay? And so his routine's out and then he's upset or whatever.
And there is embarrassment on our behalf because of him, but...
And the ones in public are the worst a lot. Supermarkets, nightmare.
The cereal
Absolute
aisle.
nightmare.
Cereal aisle is a nightmare in our house.
Yeah. Restaurants as well.
Yes.
At times.
Yeah.
Okay, so public.
So we
It's
avoid
not
as much as we
easy.
can. That's what we do. Avoid.
And you know how to play us in public as well.
Yes.
Yeah.
Skin picking is an issue for Louis. It has been, I would say, since he was 4 or 5 years old. It manifests itself mostly in him rubbing the skin around his fingers. So my understanding of it is that he has an urge to pull at his skin. If there's any loose piece of nail or skin or any open sore, he has a strong urge to pick at it. The best way, or the way he manages it most of the time, is by using Band-Aids. So on a bad day, when he's anxious, you can see him with 10 Band-Aids on his fingers. Now, this attracts a lot of negative attention because people think he must have fallen and cut himself in 10 different places in his hand. But what it actually typically means is that he has felt a strong desire to pick, so what he will do is he will cover all his fingers in Band-Aids so he can't actually get at the area. Most of the time he's very good and he will self-regulate and he will always put on the Band-Aids himself. So we do have Band-Aids everywhere, in the car, in the school bag, in the pencil case, everywhere we go we bring Band-Aids with us as an essential item. But most of the time he does manage to prevent himself doing it by covering them in advance. There are occasions when that doesn't work, and there are certain areas where it's not really socially ideal or acceptable to have Band-Aids, such as on your face. So in those occasions, if he has an open sore and picks at it, it can take a very long time for it to heal, which is not ideal. The number one strategy, as I've said, that we use is Band-Aids, which seem to work for him. Other things that he does is we have boxes of what we would call fidgets, so basically sensory toys. So the picking most commonly occurs if he's anxious or if he's engaged in an activity that involves a lot of listening and no physical movement. So if he's doing a crossword and his hands are busy, then there's never going to be any picking. If he's, however, watching television and there's nothing in his hand, then he's more inclined to pick. So we have little boxes of sensory squeezy balls and little items that one manipulates with one's hands, different types of putties and plasticines, and he manipulates those. And that the sensory feedback he gets from that seems to, I suppose, relieve the need for him to pick.
Cian, we didn't think he really had many, but he's the last year and a half, he started skin picking. So that would be one of the main problems we do have. And it can go 6 months with something staying, you know, a little cut staying open, and it might just be from an initial little scratch or something like that from his baby brother, but he'll keep it open for 6 months. With the skin picking, we've tried to introduce a little glove, kind of an elastic glove, because he usually picks his hand. So it's a squidgy kind of a thing that he pulls at. And also we've got one of those sponge balls that you get in all the €2 shops, and we've halved it. So he has it in his pocket and he picks at it because you can pick bits off it. So it's kind of a relief for him, a bit of a release. Just trying to keep him busy really, because it's quiet time that usually happens.
Peter's 43 now. Never had any behavioural issues until a couple of years ago. And that was when he went into residential care. And I suppose he wasn't as spoiled in there as he would have been at home. He was always able to just go and get his little bits and pieces at home without any competition. In the house there seems to be a bit of competition, and if he doesn't get his own way, I suppose one would say, maybe immediately he can explode. That never happened at home, but it's coming into our house now. When he comes home at the weekend, he feels that sometimes it takes him a little bit of time to adjust. And for the first night he's home, it's nearly like he's in his residential house, because it's nearly it's my turn, where he doesn't have to compete with anybody at home. And life at home is much easier for Peter, but the competitiveness of living in a residential house has made him grow up, and has given him more independence than I would have ever given him at home.
We are very lucky to say we have none.
Absolutely none.
Absolutely
She's a gem.
none. We have no behavioural problems whatsoever. She's totally normal in that respect. Like her brother and sister.
The behavioural problems we have at home is her brother and sister.
Not her.
She's a star. She's absolutely no problem.
No, there's no problem.
And her
Never
brother
had
and
it.
sister are great as well.
No.
Maybe it's just the placid father that they have. I don't know, but we are extremely lucky. Not every child has the problems that everybody is. It's such a wide spectrum. You might have this one, you might have that one. It's not total cast that your child is going to have everything that is associated with Prader-Willi.
With regard to food, there would be some issues, and with Mary Rose, it's just a funny story I can tell you. Food is on a timer. The meals are set time, so breakfast is obviously in the morning before you go to school, etc. Lunch is 1 o'clock, and dinner is 6 o'clock. And if you keep to those times, you have absolutely no problem, and she doesn't look for anything outside of those times. And if there's an agreed break time, etc., that's all fine. This was all very well when Mary Rose couldn't read the time. So sometimes when she would ask me, is it 1 o'clock? And it might be 3, and I was trying to delay lunch, she would be fine with that. But now she's caught me out, she can read the time, so lunch is 1. She is really, really into reward for good behaviour, and she is dying to get the most marbles at their table every week and win the prize for being the most. So those kind of strategies of reward and recognition really, really work. She absolutely loves recognition. She loves being told she's good. She loves being told her behaviour is good. So the giving of a reward, a token of the reward, such as marbles, stars, charts, all of this works really well in Mary Rose's case, and to my knowledge in a lot of cases of children with all sorts of backgrounds, not just Prader-Willi background, but certainly notable recognition seems to work very well for her.
The focus of my talk is going to be on some of the behavioural and mental health aspects of people with Prader-Willi syndrome, including how we best understand the overeating behaviour that is so characteristic of the syndrome. What I'm going to do is to give a brief introduction to Prader-Willi syndrome, which you will be, of course, very familiar with, and then focus on some of the eating aspects and how we best understand the eating behaviour, and then move on and discuss the temper outbursts and some of the repetitive and ritualistic behaviours, before considering some of the mental illness and the mental ill health that affects people with Prader-Willi syndrome and how we can treat it. In this slide, what I want to do is to illustrate something that I think we've learnt a lot more about over the last few years, and that is how people with Prader-Willi syndrome change over their lifespan. We're all familiar with the fact that at birth the baby with Prader-Willi syndrome will be extremely hypertonic, will be very floppy. But of course this changes, and as they get a bit older then we begin to see the excessive eating behaviour develop, and as they get older still we recognise that they may have some developmental delay, they may need special help at school because of some intellectual disabilities. But we also see the fact that they may not be growing normally because of their growth hormone deficiency. They may be sexually immature as they reach puberty. And we see the emergence of some of the other problems which can have the greatest impact on their lives. And these are not only the overeating behaviour, but the repetitive and ritualistic behaviour, and often the extreme temper outbursts that can be so very problematic. In adult life, we see some of the problems that come with independence, and particularly then we see the risk of severe obesity when access to food is perhaps no longer controlled. Also, some of the problems of later life, which include mental health problems, can emerge for the first time. So it's these that I want to go through and discuss in turn. An area of the brain called the hypothalamus is central to our understanding of many of the problems that are so characteristic of people with Prader-Willi syndrome. This is indicated on this diagram of the brain. You will see that it is a tiny, small area in the middle of the brain. It's a nucleus that controls many aspects of development, including growth and sexual development. But it's also important as the area of the brain that controls appetite and eating behaviour. So much of the research into Prader-Willi syndrome has focused on this particular area of the brain and what might be wrong in the various pathways and chemicals that make up the hypothalamus. But I now want to step back and consider some of the behaviours that are so characteristic in Prader-Willi syndrome. Over the years, there have been many studies in different countries in the world, including over Europe, in the United States and in Australia, that have asked this question: are there particular behaviours or particular mental health problems that occur in excess in people with Prader-Willi syndrome? This is findings from one such study that we undertook in the United Kingdom, and essentially all the studies have shown the same thing, and that is excessive eating is almost universal in people with Prader-Willi syndrome, although it may vary in its intensity. Obsessional or ritualistic and repetitive behaviours are very common, as are temper outbursts, skin picking, and mood fluctuations, mood swings. This is now often referred to by the term the behavioural phenotype of Prader-Willi syndrome. And from a research point of view, of course, the interest is to understand why is it that people with this syndrome have these problems and that these problems occur in so many people to such excess. From a clinical point of view, what's important is that we have the right strategies and interventions in place in order to minimise these behaviours, because often it is these behaviours that give rise to the most serious difficulties for people with Prader-Willi syndrome, for their families and for others who support them. This slide, taken from our own research, shows the weights of babies born with Prader-Willi syndrome. And I want you to imagine that below that line, below the 0 mark, then the baby tends to be thin for their height, and above that line they're overweight for their height. Now what you can see is that when they're first born, babies with Prader-Willi syndrome tend to be underweight, whereas within a few months all the babies then appear to be overweight for their height. Now this is well recognised. In other words, the baby with Prader-Willi syndrome is floppy, is underweight and fails to thrive. But of course what is very interesting is how that then changes. Perhaps from the age of 2, 3 or 4, the mother will notice that the child may be eating more and be putting on weight, and in the days before an early diagnosis was made, this was often the time that the families found that the baby became overweight because they were so relieved that the child was now eating normally, whereas before it wasn't eating. Nowadays, with early diagnosis, we can be much more aware that this transition is going to happen, and mothers and fathers can be aided in managing this transition effectively in a way that prevents obesity. But I want to take you now to later in life. Now this slide is a weight chart of the first person that I ever saw with Prader-Willi syndrome, and she was aged 18 when I first saw her. I show you this because it indicates what can go wrong if you don't manage access to food. Now this was many years ago, before we properly understood these problems in Prader-Willi syndrome. But when she was living at home with her mother and father, they locked the food cupboards, they locked the kitchen, and they had complete control of access to food. I saw her after she had moved away from home and was living in a hostel for people with intellectual disabilities. It was a very good hostel, but the staff there refused to control access to food or to supervise this person's access to food. And as a result, she ate and ate and ate, and of course you can see that she put on very large amounts of weight. And it was when she was getting extremely obese that she was referred to the service that I worked in at the time. As a result of our experience seeing this particular person with Prader-Willi syndrome, We were interested in seeing how people with Prader-Willi syndrome would behave if they had free access to food for an hour. Would they slow down at all in their eating behaviour? And particularly, would their ratings of hunger or fullness change over that time? We therefore set up an experiment. First of all, we asked people who did not have Prader-Willi syndrome to come and eat for up to an hour, and we observed their eating behaviour over that time, as well as asking them to assess how hungry they felt or how full they felt. What you see in this slide is the eating behaviour of each of those individuals that took part in the research. And what happens is, like most of us, people who don't have Prader-Willi syndrome eat fairly fast for a while, perhaps 10 or 15 minutes, but as they feel less hungry and more full, then their eating behaviour changes and they slow down their eating and eventually stop. As you will see, of course, there's quite a variation in what people eat, and that helps to account for why in the general population you see such variation in people's weights and level and extent of obesity. The next slide shows 13 people with Prader-Willi syndrome. Each of them came and they had access to sandwiches for an hour, and we said to them that they should eat until they felt they'd had enough. Here, of course, you see a very different picture. You see that the vast majority of the people with Prader-Willi syndrome ate continuously for that hour. Interestingly, when we asked them to rate how hungry they felt and how full they felt, eventually, towards the end of that hour, they did rate themselves as being less hungry and fuller. However, they'd had to eat 3 times more food than the control group in order to reach the same level of fullness and the same level of reduction in hunger. And when we continued to ask them about their hunger and fullness after the food had been removed, their hunger came back much quicker than the control group. So this suggested to us that the fundamental problem in people with Prader-Willi syndrome was what's called an abnormality of satiety. Later, as brain scanning technology developed, we were able to look at this in much more detail. And on the left side of this slide, what you see is the pictures of someone in a brain scanner, and you can see their brain and the skull. And whilst they're lying in the scanner, they're asked to make decisions about food. They see pictures of food and they have to decide their preference and so on. And whilst they're deciding about preference, the scanner is looking at changes in the brain, looking at the areas of the brain that are activated. What you see in the top left is the areas of the brain that are activated when people who do not have Prader-Willi syndrome are making decisions about food. In the bottom left, you see the same patterns in people with Prader-Willi syndrome. And although there's some difference there, they're not really very different. However, on the right-hand side, you'll see at the top, this is the pattern, the areas in the brain that are activated as shown by the colours when someone is making decisions about food, having just eaten a normal meal. So in the first slides they haven't eaten, in the second scan they have eaten. And what you find is different areas of the brain are activated. Now, I can't show you pictures of the people with Prader-Willi syndrome because in fact they didn't activate those areas of the brain at all. So the message that comes out of this research is that whilst people with Prader-Willi syndrome activate the same areas of the brain when they're hungry and they're thinking about food, they don't activate the same areas of the brain when they've eaten and supposed to be full. And this suggests again that there's a very biologically determined abnormality of the brain, which means that people with Prader-Willi syndrome do not feel hunger and fullness in the same way as people without Prader-Willi syndrome feel hunger and fullness. And this is illustrated by this diagram. This is a diagram that in a sense shows what happens when you eat. That as you eat, as food enters the mouth and goes into the stomach and intestines and is absorbed, there's a whole series of processes that are activated in the body whereby the gut informs the brain that food has entered the gut and is being absorbed, so that the person then no longer feels hungry and slows down their eating and eventually stops eating. It is this satiety process that would appear to be abnormal in Prader-Willi syndrome. This is just taken from a textbook. which summarises, if you like, the present state of knowledge about the eating behaviour in Prader-Willi syndrome. Essentially, it says that this satiety process is abnormal. What we don't know is precisely why. Is it some of the feedback from the gut that is wrong, or is it that the brain itself is very insensitive to that feedback and therefore doesn't respond normally? I think it's sometimes helpful to think about Prader-Willi syndrome and the eating behaviour as being a paradox. And at the top of this slide, you'll see a title of a paper that we wrote some years ago called The Paradox of Prader-Willi Syndrome, a Genetic Model of Starvation. Prader himself saw Prader-Willi syndrome as being a model of obesity. However, the way that I think we conceptualise the syndrome now is that effectively the brain is fooled to think that the person hasn't eaten when of course they have. So in other words, they feel hungry or starve all the time. And quite understandably, the person then continues to eat because they're still feeling hungry. And therefore, it's perhaps helpful to think about it in this way, because in those terms we can get inside the head of someone with Prader-Willi syndrome and better understand what it's like to have the syndrome. For all people with Prader-Willi syndrome, supervision of access to food will be necessary to one degree or other. This will vary from person to person and may in some cases be at a relatively modest level, but in other cases, and perhaps for the majority, that level of supervision will require things like locking the kitchen, locking food cupboards, locking the fridge door. The judgment about this will have to be made at an individual level. Some people will require a relatively minor supervision, others much more serious supervision. In addition, particularly when someone with Prader-Willi syndrome becomes an adult, there are complex and difficult decisions to be made about how you balance their right and their wish to make choices in their lives and to be independent on the one hand, and on the other, the risks that then follow, particularly with respect to their wishing to eat too much food, how they use their money and whether they use their money to buy food. And this leads to quite difficult and demanding ethical decisions that have to be made. We hope in the future that there will be medications that are developed that may be helpful in controlling this excessive appetite. But those medications that have looked hopeful in the past have sadly had side effects to them and have had to be withdrawn from the market. But this is an area where it's very likely that something will develop in the future. What I want to do in this part of the talk is to look at the characteristic of the repetitive and ritualistic behaviours and the temper outbursts, and then to take a rather research perspective, so perhaps you can understand more about our understanding of why these problems occur in people with Prader-Willi syndrome, and then look at how one might try and prevent them, or at least manage them when they do occur. One of the difficulties when you're researching behavioural problems, whether it's in people with Prader-Willi syndrome or people with autism, is that you have to somehow try and characterise the behaviour. If you're researching into physical disorders, often they're things that you can measure in the blood, which tells you something about these disorders. This is not the case in these behavioural difficulties. What this slide shows is one such way of trying to measure these behaviours, trying to characterise these behaviours. And this is something called the Childhood Routines Inventory. This is taken from a paper from a group working at the Institute of Child Health in London. And what they were doing is they were comparing the types of repetitive and ritualistic behaviours that are reported in people with Prader-Willi syndrome with those that are reported in people with autism. And what this table shows is, in fact, these behaviours, these ritualistic and routine behaviours, are very similar whether they occur in someone with Prader-Willi syndrome or in someone with autism. And this does suggest that maybe whatever is causing these behaviours may be similar across these two particular disorders. To help understand the reasons for the repetitive and ritualistic behaviour and the temper outbursts in Prader-Willi syndrome, I want to turn to the work of Professor Chris Oliver at the University of Birmingham. This was work also undertaken by Dr. Kate Woodcock. What they have shown is that people with Prader-Willi syndrome have a very particular problem, and that is sometimes referred to as set shifting or attention shifting. They find it very difficult to move from one task to the other. So if something unexpected happens, it's very hard for them to change their attention from what they have been doing to this new task. What they argue is that this problem of set shifting is fundamental to understanding the reasons for the repetitive and ritualistic behaviours. The focus of their research is not only to demonstrate the relationship between this particular cognitive problem and the behaviour, but to see if anything can be done to change it. Is there anything that can be done in childhood to help children with Prader-Willi syndrome to cope with change and to attention shift in a way that is more effective? Also, can you help people with Prader-Willi syndrome cope with change through various interventions? I want to demonstrate some particular aspect of the research that they've been doing because I think it makes a very powerful story. It's rather similar to the example that I gave when looking at the eating disorder. Because what their work shows that is if you look at people with Prader-Willi syndrome making decisions whilst they're having a brain scan, it demonstrates that there's again a fundamental problem in the brain. Now this is an example of the scans that they did. On the left-hand side, there's scans from a group of people who do not have Prader-Willi syndrome. And whilst they're in the scanner, they're asked to change their attention from one task to another. The bright red areas are the areas of the brain that are activated whilst they're doing that. On the right-hand side, you can see that people with Prader-Willi syndrome did not activate the same areas of the brain. In fact, none of those areas seem to be activated when they're being asked to do the same task as the control group. However, what they did is they activated different areas of the brain. This is again shown by the areas in red. This red area is where the brain seems to be particularly active as a result of the people undertaking this task. What this suggests to us is that people with Prader-Willi syndrome are not readily equipped to coping with change. And therefore, if change happens, and of course we all know that we can't control life and that changes have to happen, then for someone with Prader-Willi syndrome, that is particularly problematic. This is really shown diagrammatically in the next slide, and I just want to take you through this slide. The argument is that the genetics of Prader-Willi syndrome leads to some abnormality in the way that the brain develops. This in turn leads to the fact that people with Prader-Willi syndrome can't readily change their attention from one task to another, the set shifting problem that I referred to earlier. So if some change happens in their life, then of course that causes great arousal and upset. They may try and cope with that by asking repetitive questions, so they seek an explanation of what's going on. But all the time they may be getting more and more upset to the extent that they have a severe temper outburst. Now, whether this model is correct or not will depend upon the results of further research. But at least it's one way of thinking about why people with Prader-Willi syndrome have these particular difficulties and what might be done to help them. So you can think, are there ways of ensuring that there is minimal amount of change in the environment? Or if change is going to happen, can you prepare people with Prader-Willi syndrome for that change in a way that they are not as aroused, not as upset, and therefore don't have a temper outburst? I want to now to change to my final subject of this talk, and that is the mental health of people with Prader-Willi syndrome. Now, the importance about this is that mental health problems may well present with a change in behaviour. And therefore, if someone with Prader-Willi syndrome presents, for example, with a lot of temper outbursts, it's necessary to try and answer the question, are those temper outbursts the type of temper outbursts that I've just been talking about and very characteristic of Prader-Willi syndrome, and should be treated using some of the psychological strategies that I referred to? Or are those temper outbursts a consequence of some new mental health problem that has developed? Now, what we know from research is some of these mental health problems are particularly common in people with Prader-Willi syndrome, and I want to describe those and refer to some research so you get some idea about the relationship between Prader-Willi syndrome and mental ill health. One of the biggest problems, of course, is the detection of mental ill health when it affects someone, particularly someone who may have an intellectual disability. So the prevention and management of some of the problem behaviours that may arise in people with Prader-Willi syndrome really depends upon a thorough and proper understanding and assessment. Psychiatric illness, as I've said, may present with a change in behaviour, and people may be fooled into thinking that this is the characteristic behaviour of people with Prader-Willi syndrome, but in fact it's due to some underlying mental health problem. The key to determining this is a very good history and a detailed examination of someone's mental experiences, referred to as a mental state examination. Some of the clues to whether this is long-standing behaviour problems or the onset of a new mental health problem is whether, for example, any problem behaviour is of new onset or long-standing. If it's new, then you have to look for an explanation why this behaviour is occurring for the first time. Is it because of an underlying physical problem? Is it because of some big change in the environment? Or is it because the person with Prader-Willi syndrome has, as they've got older, developed a mental health problem, such as a mood disorder? So you're looking for evidence of that not only change in behaviour, but for change in someone's mental state and in their mood. Over the years, there have been many descriptions of mental health problems affecting people with Prader-Willi syndrome, from as early as the 1960s, where Kolrak and Wolf first reported such problems affecting someone with Prader-Willi syndrome, to much later, where there have been studies, systematic studies of mental health in people with Prader-Willi syndrome. Most of these studies have said that people with Prader-Willi syndrome, if they become mentally unwell, they develop a mood disorder. By that I mean depression, or the opposite of depression, which is sometimes referred to as hypomania or mania. This is now often called a bipolar mood disorder. This data is taken from a study that we undertook some years ago, in which we tried to identify everyone with Prader-Willi syndrome in one area of the United Kingdom. Of the adults that we identified in this population, we asked ourselves whether any of them or not had the most serious form of mental illness, which is often referred to as a psychotic illness. A psychotic illness is characterized by the person hearing voices, having abnormal ideas and beliefs, such as delusional ideas, belief that people are out to harm them, etc. Now, what we found in this study is that adults with Prader-Willi syndrome did have higher rates than you would expect of such psychotic illness. What was surprising to us was that that psychotic illness was predominantly in people with the UPD or disomy form of Prader-Willi syndrome. So as you can see from the slide, all 5 of the people aged 28 years and older with UPD had a good history to suggest that they had at some point in their adult life had a psychotic illness. Now, it's important to stress at this point that these illnesses are treated. The problem, I think, has been that people fail to recognise them for what they are. So I want to discuss this in a little more detail. This slide is taken from a further study that we did, in which we again were looking at the types of mental health problems that people with Prader-Willi syndrome experienced. This was undertaken by Sarita Soni for her PhD, and she interviewed many more people with Prader-Willi syndrome than we did for that earlier study. And you can see by the top bar that this is a group of people with deletion. And the majority of them, as adults, did not have a history of additional mental health problems. But a small number, 11%, had a history of a mood disorder, and another group, the ones shown in red here, had a history often of a mood disorder, but also of a psychotic illness. If you look at the lower bar, you see this is the rates of psychiatric problems in people with the UPD or disomy form of Prader-Willi syndrome. Here what you find is higher rates of psychotic illness as shown in red. So how then, if an adult with Prader-Willi syndrome presents with serious problem behaviours, do you distinguish between what might be seen as a behaviour problem and what might be seen as a mental health problem? Well, to start with, we know that, for example, anxiety and bipolar mood disorder such as depression and hypomania and psychosis are common in people with Prader-Willi syndrome, and the psychosis is particularly common in people with the disomy form. The clue to trying to disentangle the cause of this is really in the history. People with Prader-Willi syndrome may well have a long history of temper outbursts of repetitive and ritualistic behaviour. But if, as they get older, that behaviour gets much worse, or if it emerges for the first time in teenage years or adult life, you should suspect the possibility that that deterioration is because of an underlying mental health problem. It may not, of course, be due to that. There may be another explanation. But you should ask about their mental health. Is there any indication, for example, that they've become more depressed? Are they tearful? Has their sleep pattern deteriorated? Is their thinking very negative? Is there a pattern of periods of depression and periods of overactivity or hypomania to suggest that they might have developed a bipolar mood disorder? And do they describe mental experiences that would seem very odd, such as belief that people are trying to harm them or that they hear voices when clearly there are no one around? If that is the history, then you should suspect an underlying mental illness, and underlying mental illnesses can be effectively treated. So what to do under these circumstances? The first point to make, which I think is a core theme of my talk, is that intervention is guided by what I've called here a formulation. It's guided by an understanding of that person in the round, and it's guided by the fact of the theories that we know about the causes of such problems. What a formulation is trying to do is to say, this is what I understand about the person, and then they're saying, how do we best understand that person given the theories that might explain these behaviours? So there's the theory of applied behavioural analysis, for example, that suggests that behaviours are shaped and reinforced by the response of others. This has been a very powerful and important explanation of some of these challenging behaviours and has very clear implications for how you manage the behaviours and treat them. However, some of the behaviours and the repetitive and ritualistic behaviours that I've mentioned may also be a consequence of developmental arrest. The characteristic of those behaviours are very similar to the type of behaviours that you see in young children, such as repetitive questioning. The difference is that typically developing children grow out of those behaviours, whereas people with Prader-Willi syndrome may be stuck in those behaviours and not grow out of them. But the third explanation may be that of what's often referred to as comorbidity. In other words, the co-occurrence of some additional illness over and above the Prader-Willi syndrome. This may be a physical illness, and any change in behaviour, you should always ask the question, could this be due to an underlying physical illness? But perhaps more commonly, this may be due to an underlying mental health problem, the development of a mood disorder, a bipolar disorder, or a psychotic illness. So I think it's helpful to think about interventions in this way. Well, there are interventions that are directly, if you like, with the individual with Prader-Willi syndrome. Are there psychological strategies you can help the person with? So if they feel themselves becoming upset, you can prompt them to undertake some form of relaxation or particular exercise that helps them calm down. The use of psychiatric medication to treat illnesses that are known to respond to such medication can be very effective. When used for people with Prader-Willi syndrome who are mentally unwell, one should start with medication doses that are lower than normal and build them up very carefully if it's necessary to increase the dose. One has to choose these psychiatric medications with care because some of these medications make the eating problems worse and can also increase the risk of obesity. However, when appropriately used, they can help someone's mood stabilise, they can take away the hallucinations and delusions that are often so distressing. And as a result of this, the behaviour problems that have become manifest then themselves fade away. There are also changes to the support that you might think about that may help to prevent both the temper outbursts but also may reduce the risk of such mood problems and mental health problems emerging as the person gets older. This is about ensuring that there is structure and support available to people and that people with Prader-Willi syndrome are not put in intolerable situations that cause extreme anxiety and is very distressing for them. In this regards, there's a relationship between the risk of these behaviours and mental ill health and whether or not you're managing the food environment. For someone with Prader-Willi syndrome, having to make choices about food is very problematic. And that, of course, may increase the risk of temper outbursts and maybe even increase the risks of mood disorders at some later date. So managing the food environment so that you keep anxiety to a minimum may well be important also for someone's mental health. In addition to interventions that are directly with the person with Prader-Willi syndrome, him or herself, there are things that you can do in terms of the way that the person with Prader-Willi syndrome is supported. Also, there are things that you can do in the environment. Now, it's not possible to discuss all of these in this talk, and there are many examples given on various websites. But there are ways in which you can ensure that when someone's behaviour is beginning to deteriorate, that you manage it effectively. There needs to be an agreement to the type of strategies that you're going to use. If you provide information in visual format, this can help people with Prader-Willi syndrome understand what it is that's going to happen, particularly if there's going to be a change. Or it helps them have some structure to their lives so they feel less anxious and are less likely to have a temper outburst. It's important, therefore, to remember that the intervention is based upon your understanding, and it can be at a number of levels. It can be at the level of the individual, it can be at the level of the support that you provide, and it can be at the level of the environment in which the person is living. Now, all of these in some ways overlap, but together they can ensure that you minimize the risk of temper outbursts, you maximize the chance that the person remains mentally healthy and well, but also you ensure that if they were to have an outburst, you can manage it effectively, that reduces any risk to the person themselves or to those that are supporting them. I want to end the talk by just reflecting a little bit on some of the challenges in terms of supporting someone with Prader-Willi syndrome, particularly if their mental health is disturbed or that they have serious problematic behaviour. Perhaps the first challenge is to actually be able to engage with the person with Prader-Willi syndrome themselves. Particularly if someone develops a comorbid mental illness, then often they don't want to engage with any form of treatment. They may not want to see the psychologist or the psychiatrist. They may not want to take any treatment that is suggested. And this is very problematic. And it may take time to engage with the person in a way that enables you to undertake the interventions that are likely to be effective. Developing an understanding, arriving at a formulation, is often not easy, and it can't be done on the basis of just one interview. Often it's necessary to ask those that are supporting the person to keep detailed records about the behaviour, about the person's mental state and their mood, so that you can see if there's any pattern or any relationship between their mood and their behaviour. However, with time, usually some sort of pattern emerges, and it's possible to arrive at an understanding. The problem then is to make certain that you can undertake the interventions that are suggested by your understanding of the person's problem. And this, of course, again may be difficult if the person, him or herself, doesn't want to engage in any form of treatment. There is underlying all this, particularly in adults with Prader-Willi syndrome, a tension between choice and control. You want to give people, now that they're adults, opportunities to make their own decisions and their own choices in their lives. Yet, of course, what do you do if those choices are putting them at risk? If those choices means that they're eating too much and getting overweight, or if their behaviour is getting them into trouble, either because they're in risky situations or they're engaging behaviour that put themselves or others at risk. This is very difficult, and it's important for families to turn to people working within the health services of their country to seek expert advice about this. The point I think I would like to make is that there are interventions that can be done that help to manage and control the behaviour problems. There are effective treatments for mental health problems in people with Prader-Willi syndrome. However, the challenge is to recognise the problems, to understand why they occur, and to implement the right types of interventions that are likely to be effective. I hope this talk has been helpful to you, and thank you very much for listening and watching this film.